Hi, everybody. My name is Neal Shore. I'm the medical director of Carolina Urologic Research Center in Myrtle Beach, South Carolina. It's a pleasure to talk to you today about two topics in the prostate cancer patient journey. That would be high-risk localized disease. We'll talk about some of the options that are available regarding this notion that we talk about oftentimes is intensification, systemic in combination with interventional treatment. And then our patients who develop PSA relapse, which is also commonly referred to as biochemical relapse. So in other words, the category of patients who've undergone an intervention, radical prostatectomy, radiation definitively, and or both, who might unfortunately result in biochemical relapse. So I'm going to do the first part about intensification. And, the pioneering work by Bola, published in Lancet in 2002, brought us to realize that androgen deprivation therapy is a really a true mainstay component to patients undergoing external beam radiation or IMRT now, and all the various improved ways of delivering radiation therapy, whether it's IGRT or IMRT or your preference for hypofractionation strategies. But what Bola was really remarkably demonstrable in showing, and you see this here in the separation of the curves and the combination EBRT, ADT versus radiation therapy alone, is there's this potentiation or radiosensitization by combining these two therapies. And so it's really become now the mainstay for our patients, certainly with high risk prostate cancer who choose radiation, and even arguably for patients with intermediate risk disease. But there's different durations that we tend to look at. And of course, there's the benefit risk association, benefit in terms of progression and survival, but also the well-described attendant complications of T suppression. So there have been some additional work that's been done, and here's just to list some of these trials looking at a shorter duration from going from 36 months to 18 months. And these are really nicely conducted studies. This is published in European Urology by Nabid. Whether or not you see a difference in biochemical failure versus radiographic progression. And so I think the answer is it's still debatable, but there's no doubt that for patients who have the toxicity of T suppression, fatigue, hot flashes, loss of libido, not to mention bone demineralization, the quasi-metabolic syndrome, there's certain advantages. And of course, there's even some economic considerations. So we don't really have or know necessarily the optimal choice. And we're learning more and more in terms of markers to try and elucidate, do you even need to have T suppression? There's been some great work recently done with artificial intelligence, with deep machine learning, with looking at a series of retrospective samples from 5 or 6 NRG trials. That data was presented at ASCO GU by Dan Spratt. It's now actually worked its way into the NCCN guidelines. Certain patients are also receiving information from looking at molecular markers such as Decipher. And that's really, where we are today, and it's still ongoing discussion. Here's another trial known as the Peace 2 study, which is ongoing, which is looking at cabazitaxel and radiation in high-risk localized patients. And you can see it's a four-arm trial. And I think there's even some earlier phase 2 studies that have just looked at MHSPC that was presented, known as the Cascara trial at ASCO this year. It's a little bit out of the topic we're talking about, but looking at cabazitaxel and carboplatin in combination with abiraterone for high volume MHSPC patients. I think what's interesting to me about this particular study using cabazitaxel is that most of us would agree that cabazitaxel is a really much better tolerated drug than docetaxel. It's a different price point for sure. Its indication is post-progression in docetaxel. But I think this is interesting and a trial worth monitoring in terms of their final outcome readout. Yeah, this is an important trial that was published in Lancet in 2022 and presented at ESMO same year by Gerda Tard. It's a little bit complicated, but at the end of the day, these were high risk, for the most part, localized M0 patients, or what we call non-metastatic CSPC. And these patients, basically, it's a large study. In the beginning, there were some patients who received just ADT alone. Some were getting ADT and docetaxel. And then ultimately, patients were getting ADT, docetaxel, and abiraterone, a nearly 2,000 patient trial. Overall, the characteristics are pretty well balanced. There was also an arm that had Abi and Enza. Of course, we're aware of the ASICS trial that demonstrated an RPFS benefit in MCRPC patients with combining Abi and Enza, but didn't have an OS benefit. Some recent work by Dan George in phase 2 studies and Elizabeth Heath have looked at Abi-APA trials, combinations, and differentiating between white versus non-white, predominantly African American populations, and actually was presented at ASCO. It was actually very compelling, small numbers, but nonetheless very compelling, showing less hypokalemia amongst Black patients and a longer duration of response, albeit small numbers. But I think the combination of Abi, or androgen biosynthesis ligand inhibitors, and AR pathway inhibitors, I think that story still has some legs to it. But that was also one of the arms combining Abi and Enza in this particular study. I think at the end of the day, this MFS curve here really shows that the patients receiving ADT DOSI plus Abi plus or minus Enza ultimately did markedly better than monotherapy ADT. There was improvement in RPFS, MFS, as well as OS, in particularly in patients with high risk or high volume disease, depending upon the criteria that you want to use. And you can read the criteria here. But this really preceded the Arisen's data of thinking about the triplet. Granted, Arisen's was in MHSPC patients, but this was in patients who were very high risk localized prostate cancer. And so how can we do maximize androgen annihilation besides just giving monotherapy ADT and RT? So I think this was very instructive. And here's some of the criteria that you see listed here. Other trials looking at high-risk localized optimization is the Atlas trial. I'm proud to be part of the steering committee here. This trial began, many years ago. We're hoping to see a readout sometime soon, not this year, but hopefully perhaps in the next foreseeable future. And you can see the schema here of using basically apalutamide and ADT in addition to radiation therapy. And again, in patients who are good performance status, don't have metastatic disease, all done on conventional imaging, notably, because this is when these trials were started, and monitored with conventional imaging. But will there be a benefit for these high-risk patients getting ADT and IMRT versus ADT and apalutamide? And this is out to approximately 2 years. Likewise, instead of using apalutamide, we have the ANZUP organization network doing the ENZARAD trial. And here's their study schema. A fairly similar population at high risk for failed disease, high risk to develop BCR. And you see the different stratifications, 800, approximately 800 patients getting 2 years of ADT Enza versus ADT monotherapy. And I do think both of these studies will be additive to the STAMPEDE arm of adding ADT abiraterone to IMRT. So one can look now at the most recent NCCN criteria. So for patients who are, at high or very high risk, depending upon their grade group differentiation, we now have This really nice seminal work by Gerda Tard and the Stampede group has now been incorporated of a triplet therapy, so to speak, for high-risk localized disease, EBRT, ADT, and abiraterone for the very high-risk population. And I've incorporated this into my practice. And so again, you see this here, and this is really a sort of highlighting the most recent NCCN guidelines indications. So I was asked to put together just sort of a quick case, so like who might be appropriate for this sort of intensification. 65-year-old male. It's debatable if we're calling 65 elderly now. Some studies say 75, but certainly senior. PSA rises over a 2-year period. Ultimately gets biopsied and is found to have suspicion based on an MRI, 6 out of 12 cores, grade group 3. MRI potentially shows another scenario may have had a pelvic node in positive versus the first scenario not. This patient now in scenario 2 has got even more locally advanced disease. And so arguably, if this patient is not thinking about having a surgical extirpation in the form of a radical prostatectomy, I think both of these scenarios, the first one that was a little bit simplified, didn't have the node, didn't have the obstruction, but didn't have as well due to the locally advanced disease, would you then think about intensification? And thus this question, would you just recommend EBRT with ADT alone? Would you recommend it with bicalutamide, or would you add the ADT with abiraterone? And I think that's sort of the compelling aspect to that case.
Before you go on, can we just talk about that a little bit, just so I can kind of clarify it a little bit? So, and generally speaking, how would you manage patients in those two situations outside a protocol setting nowadays?
So I think in these two situations, when I have a patient now who is has a significant concern for having a risk for failure of their ADT and EBRT, whether it's by digital rectal advance, and of course that's subjective. Certainly grade groups 4 and 5. If there's MR concern for seminal vesicle invasion, extracapsular progression, some might argue the level of the PSA being 20 or higher. And also if it's 4+3, the percentage of pattern 4. I'm very much inclined to have a low threshold now for adding abiraterone, because I do think that the data, particularly in the very high risk and high risk, is very compelling. I find in my experience abiraterone outside of patients who have fluid retention, heart failure issues, and or are fragile regarding their glycemic control to be a very well tolerated drug. I think people forget the fact that abiraterone does not cross the blood-brain barrier. We tend not to see the issues, as many issues of cognitive results and or falls. I'm not bothered by having to check potassiums and LFTs. The 5 milligram prednisone BID is very manageable. Sometimes it's actually beneficial for some patients in terms of their fatigue and energy issues. And I still, although usually almost always start with the BID dose, I'll occasionally go to the QD for compliance issues and or glycemic control.
And for how long would you give the ADT and abiraterone?
So for my high-risk patients, the grade groups 4 and 5, I try to get them out to at least 18 months, preferably 2 years, and it's really depending upon their tolerability. I follow the data. I tend to be a bit wedded to that. I would potentially stop only sooner if it was any kind of adverse event issue.
And if you could access it, I mean, it sounds like you prefer abiraterone, but do you think using enzalutamide, apalutamide, even darolutamide theoretically would be something to think about or prefer?
So I appreciate the question, and the answer is yes. I've used it off-label, both apalutamide and enzalutamide. I've kind of flown under the radar with it. And I've done it largely in patients who there was a pill count concern or there were glycemic issues or heart failure issues. And I've had really good success with that, to be perfectly candid with you. I believe for these patients, that are at high risk disease, that are at 15 to 30% looking at meta-analyses at risk to fail their treatment, I want to try to lower those percentage odds. So the answer is yes.
Let me ask what may be a naive question, but just out of curiosity. So, if this patient had M0 disease, I assume intermittent therapy would be a consideration. Has intermittent therapy been looked at in this situation? Does it make any sense?
Well, it certainly makes sense if you think about, the time off therapy, where if you get any level of T rebound, patients just invariably feel better. They get back some libido, they get back some energy. And it's always appealing to patients. I'm not aware of any significant trial data comparing triplet intermittent therapy. If we talk about a triplet as RT, ADT, and an ARTA, I think that's a different discussion, perhaps with BCR patients. But I think for the folks like this, I'm a proponent of your first shot is your best shot. And I sort of take that into high-risk localized disease, or locally advanced, and also my MHSPC patients, both low and high volume, or low and high risk. I'm a strong believer in your first shot's your best shot.
Okay, please continue.
Okay, so the second part of the talk is early on these folks with BCR. And, clearly, we'd like to have no patients with BCR. We'd like to have curative intent of our radical prostatectomy, as well as whether it was done historically open or now mostly robotically, and certainly with our external beam radiation therapy approaches, we want a cure, but sadly we don't. So I think Presto is a very nice study that was presented by Raul Agarwal at ESMO 2022. This was a phase 3 open label looking at androgen annihilation in these for patients who are high risk with BCR. So here with their definition of BCR, they could have failed a prostatectomy. And we've recognized that intermittent therapy has been used historically. There's not a lot of level 1 evidence for it, but it makes sense oftentimes for patient in terms of risk benefit, quality of life issues. So there have been some studies, and probably the most prominent was the Juanita Crook, and their intercooperative group, largely Canadian sites, that showed a non-inferiority on overall survival. But nonetheless, the basis of it was really based on quality of life. So in this particular study, the Presto trial, these were just patients who were prior RPs, apparently no radiation therapy failure patients, and they had to have a PSA of greater than 0.5 and a doubling time of less than 9 months. Some ongoing trials are looking at 9 to 12 months. I think less than 9 months is consistent with a lot of the data that we have showing that has the group that has the more virulent biology and most likely to end up metastasizing with conventional imaging. And conventional imaging was the basis for this and the trial that I'll present, also known as Embark, and that's traditional CT scan and technetium bone scan. And you see they had to be eugonadal. It was a 3-arm trial where they would get monotherapy LHRH, where arm B, monotherapy or LHRH is their ADT plus apalutamide, and then arm C was LHRH plus APA plus ABI, going back to a sort of that combination. And then they were followed from progression, and they could change based upon investigator discretion. The primary objective was a PSA PFS, or PSA progression-free survival, defined as progression as a nadir plus 2 during treatment, or greater than 0.2 nanogram per ml, with 2 weeks apart and subsequent monitoring. You see the secondary objectives listed down below. T recovery, of course, adverse events and safety profile. Secondary events also of MFS. I think overall, here's the demographics. A younger group than you would expect, of course, with CRPC populations in the mid 60s. Largely white, 85%, about 15% non-white, which continues to be a challenge in a lot of our global trials. And I know everybody agrees that we have to do better, we can do better, and that's a whole separate topic for discussion. The median PSA, because these were RP failed population, is pretty low. It's under 2. And then the doubling time stratification, less than 3 months, 3 to 9 months. The time between their RP and study entry is pretty quick. Some of these patients, in fact, most of them had prior radiation as essentially in the early, what one would call early adjuvant, and possibly some might even fall into a category of salvage. And then whether they had prior ADT, the numbers are balanced here, about approximately 40%. And here's pretty much the, I think the most important KM of the presentation by Dr. Agarwal is that after about a little less than 2 years of follow-up, they do have additional follow-up that is being presented. They had a little over 100 PSA PFS events. And if you can see the curve separation, it takes place a little after 12 months. And the APA ADT arm is demonstrating here a hazard ratio of 0.52. Or another way of looking at it is a several month differential and a statistically significant p-value. The arm C was relatively comparable of the APA-ABI. I don't think it really gave a lot of difference, but again, better and superior to the monotherapy ADT arm alone. Looking at a forest plot, whether it was a doubling time of less than 3 months, 3 to 9 months, really all favored use of intensification. ADT plus APA or ADT plus APA-ABI. And no new real safety signals here that was not already well described amongst the use of apalutamide. We do see a little bit of the rash, but otherwise, fairly consistent with what one would have seen previously, and no dramatic differences in what was known in the literature. So this was PSA primary endpoint, a PSA PFS, as opposed to the MFS as being a secondary endpoint. And so the newer molecular targeted imaging tests, or next generation imaging, whichever acronym you prefer, whether it was the older fluciclovine or the newer PSMA PET tests, whether using fluorinated or gallium products, were not required. And also was not yet really well controlled or evaluated for metastasis-directed therapy. And that's an area of ongoing discussion. So to their credit, this was the Presto trial was the first phase 3 study to report an ADT plus an AR pathway inhibitor, apalutamide, in the BCR population, and they clearly had a successful PSA PFS of several months, was highly statistically significant. There didn't appear to be any real additional benefit by adding abiraterone to the apalutamide arm, and they didn't have an apalutamide monotherapy arm. They're doing follow-up impact and estimates. There is more data that's being presented, and I think there was some, we may want to talk about that later, some updated analyses that were presented, I believe this year at ASCO as well.
Just a quick question that may relate to what we're about to talk about. I found it kind of surprising that there's less than 10% erectile dysfunction. Does that sound like what you see in practice with just even ADT?
Yeah, that's a, so yeah, okay. So here they're saying in the monotherapy arm, they had they had 6% erectile dysfunction, grade 2, and then of course grade 3, grade 4. Yeah, for patients who are certainly going to be on ADT, I think the erectile dysfunction is upwards of 95%. I invariably tell my patients if they're getting started on ADT, let alone ADT and an ARPI, they're going to end up with nearly 100% sexual dysfunction impact. There are occasional exceptions to that.
I just asked you more as a prelude to talking about Embark, but we'll get into that in a second.
Okay, so I had the privilege to present for the first time our results from Embark, and that was presented at a plenary session at the AUA this year, and we're currently pending our publication. So the Embark trial, interestingly, it took, we began enrolling in 2015. We finished enrollment in mid-summer of 2018. So we had our readout just literally in the end of April at AUA, an 8-year trial of over 1,000 patients. So a really Herculean effort by a lot of sites all over the world. As we recognize, even with definitive interventional therapy, surgical, radiation, or both, we see failures, and thus the BCR population. Then we have really limited evidence as to, what do we do in this population? Continuous versus intermittent, the combinations, whether it's early generation AR blockers like bicalutamide alone, and ADTs, and there's a limited amount of really high quality data. And I think that I'm really proud of the fact that we were able to take a trial of over 1,000 patients with 8 years of follow-up to get to the results of Embark. And we stratified for a high-risk BCR, so patients who had doubling times of less than or equal to 9 months. And there's really pretty good data on that. Plus, your Gleason grade group and your time to PSA relapse are some of the key factors which suggest a higher likelihood to develop metastasis. And so we've had, great evidence over the course of the last decade that adding an AR pathway inhibitor or an AR signaling inhibitor or an androgen receptor targeting agent, we have all these great acronyms, but essentially drugs like enzalutamide, we see its benefit in MCRPC, post-chemo, pre-chemo, NMCRPC, and now in MHSPC. And this data shows its advantage and its level 1 evidence advantage in BCR. So that's thus we're keep adding to the continuum, and that's what the objective of Embark was, to see in a 1-to-1-to-1 randomization in enriched BCR patients, failed RP, failed RT, or both, comparing monotherapy ADT versus combination ENZA with ADT versus a monotherapy AR arm of just enzalutamide. And so naturally in that arm, you wouldn't see T suppression. And here's the study schema. I just explained it. You can see the patient population, the stratification factors. The patients were blinded, in the combination enzaluprolide arm versus the monotherapy luprolide. They got a placebo. Of course, we weren't going to give the monotherapy enza patients a placebo injection, so they were unblinded. Now, what was really kind of cool about this study is at basically at 9 months, if the patients got to a PSA of less than 0.2, they got a treatment holiday. And they remained, they were on treatment holiday until they had a rising PSA of 2 versus 5 in the RP, RT arms, respectively. If they didn't get below a nadir of 0.2, they remained on continuous treatment. The primary endpoint of our study was not PSA PFS like it was in Presto, but rather metastasis-free survival. And we had a blinded independent central review, and you can see all the various key secondary endpoints listed in the table. Like Presto, an older population. Ours looks to be 1 or 2 years older at the median, but otherwise balanced. Like the Presto, we were largely a white population. Similar stratifications of less than 3 months, 3 to 9 months. The median PSA was a little higher, it was about 5. But you see the breakdown here between, under 10 and greater than 10, balanced across the 3 arms. 75% of the patients underwent RP. Only about 25% alone received RT. And here's really the kind of the money slide, the KM demonstrating that the patients who had combination in the blue curve had a improvement in metastasis-free survival, and the hazard ratio there is 0.42. And looking at the 3-year rate versus the 5-year rate, one can see the percentage differences. And this is largely driven by radiographic progression. For purposes of time, I'm not going to show you, but there's a trending in survival benefit, but it's not statistically significant. I showed that at the AUA. It actually has a p-value of less than 0.05, but it's not statistically significant based upon our statistical analysis plan. We are following those patients, and we're optimistic to report on that survival outcome sometime in 2025. Looking at a forest plot subgroup analysis, whether it was doubling time, age, geographic location globally, baseline PSA, use of prior hormonal therapy, RP or not, and really pretty much everything across the board favors the combination arm over monotherapy ADT. And so I think this is dramatically important for these patients who have been worsening biology based upon the definitions that we talked about for high risk. The PSA PFS, similar to Presto, you see a hazard ratio of 0.07. I mean, it's almost a flat line, but it not entirely. So that's certainly reassuring to patients and to physicians. And so that was met. Other important secondary endpoints, starting a new therapy, a new anti-neoplastic, and that creates that whole cascade of all the great therapies that we have, but it has major implications to patients and their quality of life, not to mention health economic issues. But keeping patients sensitive for as long as possible and not requiring typically other pathways, largely for resistance reasons, clearly favoring the combination over the monotherapy, a hazard ratio of 0.36. Likewise, and sort of fascinatingly, we also saw that the monotherapy enzalutamide, based on the 160 milligram dose that's been approved throughout the prostate cancer spectrum in more advanced disease, also bested monotherapy ADT with a hazard ratio of 0.63. Likewise, there's a trending in survival benefit. Likewise, we don't have maturity, so I'm not showing you those. I did present that at AUA. And what I'm just showing here, again, for purposes of time, is other secondary endpoints, the PSA, PFS, time to a first use or a new anti-neoplastic therapy. Again, like with the combination of versus monotherapy ADT, monotherapy Enza was better than monotherapy ADT. Safety profile, no new real signals at all regarding the use of enzalutamide. There's been use of this drug now for over a decade globally. So, just looking at these three arms, the percentage of AEs, the serious AEs, relatively all consistent. The permanent discontinuations are also relatively consistent, a little bit higher in the use of enzalutamide versus monotherapy ADT. But the treatment emergent adverse events, I think it's important to note in the monotherapy Enza, the issues around gynecomastia, breast enlargement, some nipple pain, nipple tenderness. We've seen this previously in a trial we did in active surveillance known as the ENACT. We've seen this issue in unopposed AR inhibition when you don't lower T, because when you're not lowering the T, you also have some unopposed higher levels of estradiol as well. There are ways to mitigate that. We were not particularly aggressive in doing that, but that's a separate discussion. Looking at the TEAEs of special interest, a little bit more on the fatigue side, all grades. The grade 3, 4s are a little bit higher, 1.7 in the monotherapy ADT versus the combination or the Enza arms. Not really surprising. Enza has a known crossing of the blood-brain barrier, but fortunately it's in a small percentage of patients, but it can lead to some issues regarding cognition. It can lead to falls. But patients who had history of seizure or anything close to that were excluded from the trial. So ultimately, our conclusions, in this selected high-risk BCR patient population, enzalutamide combination compared to monotherapy LHRH, leuprolide, statistically significant, clinically meaningful improvement in MFS, hazard ratio of 0.42, p-value less than 0.0001, consistent across pre-specified subgroups, delay in PSA progression, first anti-neoplastic therapy. We also demonstrated that the enzalutamide arm, this is really kind of think about it, it's like two trials in one, really. Demonstrated also a positive hazard ratio. Similarly, it's demonstrated PSA PFS benefit, time to new anti-neoplastic therapy. We are going to be presenting at ESMO some additional data looking at the sexual function data that we collected, and we're still poring over a lot of that data. A lot of the questions I get asked the most, Neal, are about the potential for using enzalutamide monotherapy and not having T suppression. Folks are real interested in the fact that we were able to have a treatment holiday, which is another way of kind of thinking about, intermittent therapy. So, this has been submitted to the FDA as a potential new standard. I certainly am optimistic that they review the data favorably, but we'll wait and see. Our publication should hopefully be coming out before the end of the summer.
Just a couple of things, and I know you're not going to answer with specifics, but the thing I keep asking GU investigators is, first of all, have you ever used intermittent enzalutamide without ADT? Which, as far as I know, I think very few people have ever even done it. And I'm curious how that actually happened, that it got put in the trial. And second of all, you would think, and that's why I brought up the issue of the erectile dysfunction in the apalutamide study, you would think that they would have better sexual function, but I'm getting pushback on that from investigators. So I know you're not going to tell us the data you're going to present at ESMO, but do you see better sexual function with enzalutamide monotherapy in general, particularly intermittent?
Yeah. So really important questions. I do off-label things whenever I can, when I have a really motivated, understanding patient. By understanding, I mean intellectually understands what we're trying to accomplish. Oftentimes, it's driven by them. And I've used bicalutamide for some of these patients. And even though in the U.S. and North America you're theoretically limited to the 50 milligram, I've gone above that and documented it for whatever it was worth. And but when it came to enzalutamide, or any of the other novel hormonal agents, I haven't, except on this trial. And mostly because I guess I thought, even though I might have been able to give somebody some samples for a while, it was just going to be cost prohibitive unless I was able to get it under the radar. And I didn't really try that. Although I have done other things sometimes that just because I think it's the right thing to do for patients. I was doing trimodal therapy prior to the results of Peace One and Arisons, just because I knew it made sense, right? I mean, why not give somebody 6 cycles of Dosi? I didn't give it all concomitantly, but I give ADT Dosi, and then once they finished, I'd start them on APA or Enza. I mean, just like, how do you not? When am I going to wait? I was really happy when that data came out, and I was able to get those patients paid for. There's not a lot of data on intermittent use of the more advanced AR blockers like Enza or APA or Daro. And you're right. It can cause some sexual dysfunction, and it's not a panacea in terms of you won't get sexual dysfunction. But I think what we're teasing out right now, Neal, and we're trying to do as much work on this as possible, is getting a better understanding of, yes, erections, but then also libido. I mean, you pretty much wipe out libido, and so I'm not a sexual function expert, but we're bringing in other people who really are. It's like their entire careers are, and to try to really tease out. There's so much learning to be had, in addition to the other negative effects of T suppression, whether it's on bone demineralization or QT prolongation or central
Hot
adiposity.
flashes.
Hot
Hot
flashes.
flashes.
Yeah, can be
I mean,
brutal. As
I don't think.
Yeah,
I mean, do you get hot flashes from enzalutamide?
you really typically don't. So you're
So I mean,
absolutely
yeah.
right. Great point. Yeah.
Well, incidentally, what happens in breast cancer in the adjuvant setting, which is sort of similar to here in a way, is they know if they do both LHRH agonists plus, say, tamoxifen, you have a greater anti-tumor effect. But if the patient's low risk enough, the absolute benefit you get by adding on the LHRH agonist is very, very low. And from their point of view, it's not worth putting the patient through that. And I
Yeah.
kind of wonder whether or not you all are going to start to get into that same concept of maybe even though they have, quote, high risk disease, maybe they're not as high, maybe they're older and the patient just would prefer it. But it's amazing how I think analogous. The other thing I'm curious about is Presto did not use intermittent therapy, correct?
Correct. They didn't have a holiday.
What actually led you to do the intermittent therapy? And also, what led you to have that third arm? I'm really curious to see what will happen over the next couple of years. It's such a epic study, really. Why don't you finish out with your two cases?
So here's a quick case that could have been a case that fit very nicely into the Presto trial or the Embark trial. 70-year-old white male, 18 months, year and a half after his radical prostatectomy, PSA is now 5. He's a doubling time of 6 months, and I always think you can do back of the envelope. I use the Memorial Sloan Kettering algorithm. I like to put in at least 3 data points over the course of a year to a year and a half. Conventional imaging in both trials was used, negative. A healthy patient, ECOG 0, of course, the typical sort of other comorbidities and medications for hypertension and dyslipidemia. Profiling not done, which I do genetic profiling now in virtually all my patients. The genomic risk classifiers in some, but certainly genetic profiling now in all. And what would you do for this patient? He's got a rapid PSA doubling time. He's in good health. So yeah, do you go with monotherapy ADT? I guess you could think about intermittent versus continuous. Based upon the trial data that we've seen, there's the options based on the trial data. None are yet approved. None have regulatory approval, but based upon data, ADT APA combo, ADT ENZA, Embark, APA, Presto, monotherapy ENZA based upon Embark, or not do anything and just wait for the patient to develop imaging positivity by conventional imaging, or one can certainly add an F and say, well, what would you do now if they had, a PSMA PET positive scan? And so here are those questions. Genomic molecular markers. There are these different ones that you see here. Again, genetic alteration testing, PSMA PET. And an area that's very exciting and interesting is metastasis-directed therapy. Probably most of it'll be radiation. Occasionally there can be excision, whether it's excising lymph nodes. And then the unclear use of, combining T suppression for these patients, or combining T suppression with an ARP. So these are great, I think, discussions to have, and we're moving the ball forward to help patients live longer.
So just a couple final questions. First of all, these genomic assays like Decipher, et cetera, have they been used in the biochemical relapse setting? I've only heard about it with localized disease.
Yeah, you're right. These are primarily of value in the localized setting. Absolutely. Making decisions regarding the need for adjuvant radiation therapy, the need to move forward with interventional therapy, adjuvant radiation, and if going with radiation as the primary, the need for ADT versus not.
I didn't know that last thing. That's interesting. Final thing is just to clarify, in patients where conventional imaging is negative, they have biochemical relapse, and the PSMA is positive. First of all, do you treat those patients as metastatic disease like any other patient? Do you need to see a biopsy? Or do you treat them in any way differently? I mean, let's say than low volume disease. I mean, obviously, if they have a oligometastatic disease, you can go into that whole thing. But basically, you flip them over into metastatic disease.
Yeah, it's such an important question because there's variability on where the disease is positive. Is it a false positive? We see a lot of false positive in rib lesions. Is it an isolated supraclavicular lesion? I mean, how likely is that going to be positive? I mean, it can be. Can you biopsy the lesion? Is it big enough? Do you have an interventional radiology team that's comfortable in going after a less than 1 centimeter nodal soft tissue lesion? Probably not. Most are. If it's a big lesion, can it be, is it prostate? Could it be something else? Can there be discordance? I think the answer is that it's if you can potentially think about an SBRT to a node that looks like it and it's near 1 or 2 and they're confluent, and there's an opportunity based upon trials like Comet and Oriole and Stomp, which have those small phase 2 studies, but what they've shown is that we can delay T suppression. There are more and more phase 3 trials that are ongoing. And And so these are really important questions that I think we're all grappling with. And then if you're going to use SBRT or SABR, do you add a systemic therapy? I think these are great questions and areas to continue to really do important clinical trials to see if we can, better stratify who benefits from what line of therapy versus the other.